right. Um, Welcome everyone to today's coffee talk. We have some outstanding speakers, but before we get started, um, we like to always start in a good way. So I want to just offer us a quick prayer, and then we'll get going. So if just bow your heads with me, and then pray in your own way. Gracious Heavenly Father, we just thank you for everything you've done for us, and we thank you for all your many blessings, Father God. And Lord, I just ask and pray you just continue to be with each and every one of us as we try to take care of the best of our patients in our communities and our families, dear Lord. Lord, I ask and pray you just continue to watch over us, and I ask and pray you just continue to bless each and every one that's on this call, dear Lord. Continue to watch over them and their families, Father God. Lord, I ask and pray you just continue to give us wisdom, knowledge, and understanding every day, dear Lord. And with Thanksgiving coming up, dear Lord, I ask and pray you just continue to be with all our families and those that are in the military. I know we just celebrated Veterans Day, but those that are in the military may not be able to come home, Lord. I ask and pray you just continue to watch over them and guide them. Lord, I ask and pray you be with our tribal leadership, wherever they may be, whatever they're doing, Lord. We ask and pray you just continue to uplift them and their families, continue to help them as we continue to strive to do the work in any country, Father God. So we just ask and pray for all these things. We just give you all the honor, glory, and praise today in Jesus' name. Amen. Ha Madawe, Nainimi, it's Robert Coffey, Sa Namana. Hello, everyone. My name's Robert Coffey. I'm a citizen of the Comanche Nation, and I welcome you to this today's version of Coffee Talk. Um, this is part of the HIMSS Indigenous, Native Indigenous community, and we, under the HIMSS umbrella, we've started this community for about 2 or 3 years, and we've kind of grown it to where it's at now. If you're not familiar with HIMSS, HIMSS is the Health Information Management Systems Society. It's the largest health IT nonprofit organization in the country. But we under HIMSS, we have the Native American Indigenous community, and we're trying to reach out. There's a chapter in every state, and so we've been trying to get tribal liaisons in every state to um, bring tribal issues, tribal health IT issues to the forefront. Um, and so I think right now we have 7 or 8 tribal liaisons in the country, and so we're looking to add more. But that's all for HIMSS, and we're lucky enough to do this collaboration with National Indian Health Board, and we're excited that hopefully we can continue to do more partnerships together. So, Sophie, if you would take it away and talk about NIHB and what you do.
Yes, thank you so much, Robert Coffey. I'm excited to be part of this all with you today. I'm project lead for the Tribal Public Health Programs at NIHB. Thank you all for attending this joint session with the HIMSS Native American and Indigenous community and NIHB's Tribal Public Health Data Modernization Learning Community. Some of you may be already familiar with our tribal public health community here at NIHB. It was established for tribes, tribal health organizations, and public health and health professionals to learn, engage, and raise questions about issues related to tribal health, public health, and healthcare related topics, including tribal data modernization, tribal data sovereignty, and data governance. Once again, thank you all for attending. We truly appreciate you all and would also appreciate your valuable feedback for these sessions. So I'll be posting a session evaluation into the chat at some point during the session, and we'll also send out the link to the evaluation and follow-up emails to everybody registered. Thank you all.
Thank you, Sophie. Appreciate that. And so now to our speakers. They've been doing some work in Indian country, and they'll have some presentations. And I'll just basically let them introduce themselves as well. But we have today Dr. Eric Coles and Mason Emmerich. And I don't know, I'll just let whoever wants to go first, let you introduce yourself to the.
I guess I can go.
Uh,
Halito, everyone. It's great to meet you. I'm Mason Emmert, the epidemiologist for the Choctaw Nation of Oklahoma.
And hi, everyone. My name is Eric Coles. I'm the public health officer at the Tule River Indian Health Center, located on the Tule River Indian Reservation in the Central Valley of California.
Excellent. Well, I know you guys have presentations, so whoever wants to go and present first. Dr. Cole, since you want to go ahead?
Sure. Yeah. Yeah. Let me just share my screen. And great. If there's any issues with the slides, please let me know. But I'll go through a presentation. I'm really looking forward. Really exciting to see so many people here to learn about data modernization in Indian country. I'm going to go through these slides, but really looking forward to the conversation and to the questions afterwards. So, like I said, I work at the Tule River Indian Health Center. I've been working for the tribe now for just over 5 years. I started in 2020. And to give more background on the Tule River Indian Health Center, so I'm an employee of the health center. We're 638 funded. We're a tribal health organization. We're a member of the California Rural Indian Health Board, which is we're in the California IHS region. We're in the kind of the Central Valley, so the bottom is the map where the tribe is about halfway between Bakersfield and Fresno in the Central Valley of California, the foothills of the Sierra Nevada mountains, which has just gotten a lot of snow and a lot of rain recently. There's 84. The tribe has 84 square miles. There's about 1,600 residents on the reservation and about 2,000 tribal members in total, which is actually in California, slightly on the larger side of tribes. And even though we're a different health clinic, we were delegated public health authority from the Tule River Tribe of California in 2023. We had other public health authorities during COVID, but our current public health authority was delegated in 2023, which will be really, really important later on in the conversation. So my interest and our interest, I would say, in data modernization and in public health surveillance began during COVID. So I was brought on in the summer of 2020, and at that time, the tribe and the clinic had no surveillance system for communicable diseases, including COVID. Throughout COVID and for the first 3 years of COVID, we set up a online system to use for our disease surveillance of COVID. We monitored 900 cases and 200 contacts. We brought in staff from different departments to do contact tracing locally. So we didn't the county if the county found a COVID case on the reservation, they would kind of take the case out of their contact tracing system, and we would do the contact tracing locally, which we found to be more effective. And we also had our own quarantine and isolation orders that people followed, and then we also coordinated with the tribe to have gift packages of food of anyone who was quarantined. Them and their families would get food and supplies to make it through the isolation and the quarantine period. This shows a question kind of throughout COVID that we kept asking was how many COVID cases are on the reservation. I report to a tribally elected board of directors, and that's what they kept asking me. And we were using the clinic's data, so people who were tested at the clinic, we were reporting that as a number of cases on the reservation. So on the left side is kind of the community flyer. This is what we distributed to the community in August of 2020, so very early on in COVID, a very kind of simple, basic flyer. And then on the right is where we ended towards the end of COVID. This is from 2022, like the tail end of 2022. We were had a more sophisticated and we're doing more data alerts. But where we went to, but all this was being disseminated to the community, so people could know like kind of the risk factors and the risk level in their local community. And what I learned throughout the question of COVID cases on the reservation was that I always said that, I can't be positive that's every single case because we weren't getting any data from clinics or from healthcare organizations off the reservation. Sometimes that data would trickle back in that like so-and-so was at showed up at the local hospital with an extreme case of COVID or something like that, but that wasn't guaranteed. So it was always kind of like limiting us in how many actual cases of COVID were on the reservation. So hopefully this group is really familiar with electronic case reporting. But for us, it was really exciting to hear about the potential of ECR. I hopefully don't get into it, but if there's any questions, would happy to explain it. But it gave us the opportunity to receive the data from healthcare organizations not on the reservation through the automatic ways in the EHR. So that was just a huge expansion and a huge gain for us. We'd be able to combine the data from healthcare organizations off the reservation with our own metrics from our healthcare side to build a comprehensive number of COVID cases or any case any of the number of cases of communicable disease on the reservation. We also felt when I looked into it more that connecting to ECR there's no charge for it, so it's relatively cost efficient, kind of hopefully cost efficient, and it would allow us to receive the cases directly. So we had a lot of back and forth with the state of California throughout COVID, and ended up we did not have access to the state surveillance system. So it was very important for us to get the data directly from healthcare organizations because we weren't able to get the data from the state. So when we started to really pursue ECR and look into it, our first step was to get Tribal Public Health Authority. So this is a public document. It's a tribal resolution from the Tule River Tribe of California, resolution number FY 2024-42. This is our legal authority to act as the tribe's public health authority, which was really, really important, essential first step, really. And it took a lot of convincing and a lot of back and forth. I was not involved in all of it, but this is the exact wording. So we have limited public health authority as the public health authority for the tribe to collect communicable disease data. This is literally the screenshots from the actual resolution that Tribal Council passed back in November of 2023. So once we had that public health authority, we could actually start looking at systems and that kind of operationalizing it all. So what we started with was we met with and looked at all these different system options. And my opinion is that there is not one best system. It's really like the system that fits the needs of each tribe, of each jurisdiction. So I'm by no means saying any system is better or worse. I think it's all very context dependent. But you'll see here too, there's a lot of like kind of big companies we looked at, big systems, and smaller systems. We also looked at essentially outsourcing the process to consultants. We looked at integration engines that would help us manipulate the data and get it from one system into another, which was a big issue. So we met with all these. I think we got quotes from just about all of them. But what we ended up going with was Damagi's ComCare, which I'll explain more. But Damagi, they do a lot of global health, so they might not be too familiar with people who work domestically. A lot of stuff outside the U.S. and they're used mainly for community health workers, CHW type work, and they're used to working in kind of low resource areas and areas that are very, very rural. So that helped us. And this is again, this is a screenshot from their kind of their public facing shot. So the bottom shows you how you develop it. So what was really great for us, because this is disease surveillance for us was all new, was for us to have the ability internally to design our own forms, our own surveys, and our own questionnaires. We didn't want to have to go back and forth with another developer from the system. We're able to do that all ourselves. So it's kind of similar to Google Forms if you use that a lot, where you can kind of create your own. There's like skip logic, and there's a lot of potential for it, but you can do it all yourself. You don't need to rely on the developer. So I've actually designed most of our current forms, which is great. It's a really simple to use, easy platform. And then our contact tracers, our kind of disease intervention staff, they see something on their mobile device. And what's cool is as you develop it, you can preview it on the right side of the screen. It looks like a phone. Is this like a preview? So you can see how it would look to them. So I can kind of like pilot things myself and then send it out to them, and our DIS staff can look at it all. The other positives were like it's relatively cheap, which was obviously important for us for being kind of like a small community and a small clinic. It also was really important as an API, which hopefully you're all familiar with. I don't know all the technical details there, but it allowed us to directly ingest the data that we're getting, the ECRD we're getting directly into ComCare. So that was a huge part of for us. We wanted to kind of automate the process as much as we could. So so basically the ComCare system kind of like plays well with other systems that we're able to connect it through an API. What we should have known before, which kind of did cost us a little bit, was that we use a lot of Apple products at the clinic, like a lot of our business phones or iPhones. So we actually needed to buy new products because this is not supported on any Apple product. You have to have the Google Store. So we had to buy new products, like kind of new tablets for our staff to be able to use this system. So what we ended up doing after a few months and a lot of outside some kind of technical support is this is our public health data flow diagram. It's kind of complicated. I happy to get into it in more detail. It's definitely each step was something we worked really hard on. But in general, hopefully, if I could kind of make some sense of this, is in the bottom left corner. So again, we're a health clinic. So we have a healthcare team. Next Gen is the name of our internal EHR, and we, in addition to receiving ECRs, we also connected to transmit to send ECRs as a healthcare organization. So we're sending EICRs and RRs into AIMSS, just like other healthcare organizations are, which is the green box. CalReady is the state communicable disease system that, again, we're told we don't have access to. So our medical staff are still reporting into CalReady, and I believe they're still getting they get some data from AIMSS too, but that's completely separate from us. So kind of the top right corner, I think, is the most important. That's literally our public health department. The box is kind of like dotted out because we're technically a hybrid organization where we're trying to keep our public health program processes and systems different than our healthcare side to stay in compliance with HIPAA. But how we connect to AIMSS is with an SFTP connection. So we have access to a shared SFTP folder where we receive our EICRs and our RRs from AIMSS. And then we developed RCode, which is actually based on the state of Wisconsin. They were super helpful and they were wonderful in sharing us some RCode that they developed that helps migrate and aggregate the files that are in the SFTP folder into one table, basically. And then through an API, we send that table into our disease surveillance system, which is Damagi's ComCare, about once a week. Excuse me. And that's been going pretty well so far. We still have some data quality issues. We're still seeing duplicates, which is, I'm sure, an issue that other people have brought up before. And we're also we have other minor issues too, but we're working it out so far. We've been live for about I think 2 months or so now in terms of actually looking at the data. Our disease intervention, like our contact tracers, have access to our surveillance system. And then we're actually working with the county on doing some collaborative contact tracing. This has already kind of been working out. Unfortunately, we had a recent STI case that was very complicated that we spoke with the county about and we're working on together. Where we want to go in the future is to use Power BI, kind of like a phase 2, to use Power BI to create public and internal dashboards. Those we're still just early development, so maybe sometime next year. But what's great about ComCare too is that they have a strong connection to Power BI. We were told, so we need to look into that. But where we're going is to do data dashboards. So kind of in sum, I'll just kind of briefly kind of talk about these lessons learned. our early issue was legal. It had nothing to do with epidemiology, nothing to do with technology actually either. It was to get that public health authority, that tribal resolution. Since we're not a tribal government department, we needed to be declared designated as a tribal public health authority to get connected to AIMS and to get access to anything really. When we looked at all the system options, there are lots of free and cost saving options. There's also options where people can do everything for you essentially too. Um, so again, I don't think there's any single best answer there. In terms of a lot of the issues with the data coming in from AIMS, I don't think anyone has the answers. I went to ECR conference earlier this year with big states, and they have the same issue, obviously at a much larger scale, but a lot of people have issues around duplication, around data quality, the size of EICRs too. So it's exciting to see that everyone's kind of working together, and there's a lot of support. As I mentioned, we got our code from the state of Wisconsin, who were really friendly and really helped us along. As I mentioned, we're sending and receiving EICR, so there's room to improve it on both sides. We're realizing some of the data issues we're running into is because of our clinical staff, which is really hard to get them to change anything, but at least we know where the issues are and that where we can potentially make changes. There's significant room for partnerships because our community we serve is so small. We have a lot of kind of extra room in our surveillance system, for example. So talking with our tribal epicenter and maybe partnering with them or other tribes, I think there's a lot of room there. And then just wanted to put a plug. If there are any tribes interested, there's funding available. I think through November of 2027, there's a tribal implementation center that I would encourage if anyone's interested to look at for potential funding. But that's it. I want to say thank you, and I look forward to the conversation after Mr. Emmerich goes.
All right. Thanks, Dr. Coles. I remember first time we met was at HIMSS about, what was it, 2, 3 years ago. And you and I were both sitting together at that round table, and I had never heard of ECR. And, everyone was already fast and furious on the implementation. And I was talking, we had the CDC folks at our round table, and I was asking them, how come you didn't go out and do tribal consultation with tribes about this? Because I guarantee you, I go back to Oklahoma and I ask our public health officials, and they're going, what's ECR? Sure enough, when I went back after the conference, they go, what's ECR? What's ECR? But it's exciting because I remember you talking about those steps that you're getting ready to take. And I recently saw a map that showed the number of ECR implementations all over. But if they stripped away all of that and put just tribal uh, institutions on ECR, I, I can only imagine it'd be, you know, less than 10. But I don't know. I don't know, honestly. I think you and Turtle Mountain, I think, are the only ones I can think of right now. But I think that's an amazing accomplishment. I have so many questions. But before we get to that, let's go to Mason. He's got his presentation, I believe, queued up. So, Mason, I will turn it over to you and let you introduce yourself and the work you're doing in Indian country.
Thank you, Robert. And so I will share my screen. Can you see that okay?
Yes.
Okay, perfect. Um, let's see. Well, again, hello everyone. I'm Mason Emmert, and I'm the epidemiologist for the Choctaw Nation of Oklahoma. I have the privilege of serving on the National Advisory Council for the Agency for Healthcare Research and Quality. And then I'm also a second-year medical student at the OSU College of Osteopathic Medicine at the Cherokee Nation campus. And so just a bit brief background about the Choctaw Nation. So we're the third largest federally recognized tribe in the United States with over 225,000 tribal members nationwide. We were the first tribe to cross the Trail of Tears, and we were called the historic boundaries of the Choctaw Nation Reservation home there in southeast Oklahoma. And so that encompasses all or part of 13 counties. And it's really the geographic size has been something kind of driving a lot of our public health disease surveillance and a lot of our modernization efforts. And so the Choctaw Nation's vision of living out the Choctaw spirit of faith, family, and culture is, of course, evident as we continue to focus on providing opportunities for growth and prosperity. And so the Choctaw Nation Health Services Authority is really the hub and heart of the Choctaw Nation healthcare system, providing an array of healthcare services to over 38,000 members. We were the first tribe to build our hospital using our own funds in 1999 in Tallahena, Oklahoma. And we currently operate, I believe we're up to 10 now, outlying clinics across the reservation, including diabetes wellness centers, our behavioral health facilities, and then, of course, our fitness centers. And so within Choctaw Nation Health Services, public health is really, we're directly integrated within CNHSA, right there alongside our clinical services and other healthcare programs offered by Choctaw Nation. And this integration has really served us well. It's allowed us to work directly with our clinicians, our health service associates, and others to provide that guidance and resources for disease surveillance and public health concerns since our development. And so the department started really early 2023. So we're approaching about 3 years now. And really, this kind of delves into the underlying reason we've looked into disease surveillance. And so, really starting from the ground up, when we started back in 2023, we realized we had to identify what issues our reservation faced before we could begin addressing them. And so, really looking at the available data, we noticed a lot of that, of course, was conducted through state level disease surveillance, which then, of course, gets transitioned up to CDC level. But like many tribes, we face the difficulty of obtaining that local and state level disease surveillance data, um, not necessarily placing fault at all on the state or any of those entities, but they, of course, have their processes, data cleaning, and things of that nature. And so that significantly disrupts our ability to gauge real-time disease risk within the reservation. Most of that data that we would receive is about a year or older. And so, of course, that really doesn't tell us which counties are facing the biggest health issues, which counties need additional resources, and which of our healthcare facilities needs to gear up for additional surge of patients or different public health risks that might come about. And so, to understand the disease risk within Choctaw Nation, and really what we prioritize, our initial bout of disease surveillance was to launch internal disease surveillance. And so, having so many health facilities across our reservation boundaries really allowed us to have a trove of data coming in. And so, really, from there, we were able to go in and you can see this was our initial public health internal dashboard. And so these are all powered by Power BI. And so it connected directly to our EHR, our health record system, which at the time was RPMS for those of you within IHS realm. And so that included our respiratory virus surveillance, and that was RSV, influenza, and COVID-19. And of course, since then, we've expanded it to numerous other health conditions, but you can see the information available to you right there, kind of on demand. And so, utilizing these dashboards, it really gave us the ability to gauge real-time disease risk within the reservation, drill it down to the county level, but also able to look at the health facilities as well, so we can see which counties are having greater risk, which counties are needing those resources, and which counties are we seeing surge of conditions that we might not have seen previously. And so you can see a couple more examples here. Right there's our flu dashboard from last year, and then there's our RSV dashboard as well. All of them contain about the same general information, and it allows us to adjust that timeline to really measure that shift across different periods of time. And so using that same connection, we were able to launch our phase two of the project, which was our public facing dashboards. And so this consisted of the Respiratory Health Hub, which is public facing on the Choctaw Nation website. It utilizes that same data stream as our internal dashboards and updates automatically on a weekly basis, informing the public. Of public health trends with respiratory virus season approaching, but also not revealing any PHI or any confidential information there. We recently relaunched our respiratory health hub, giving the upcoming season for respiratory viruses. And so here's kind of the schematic, a brief overview of our internal data sources for disease surveillance. Our health analytics team within the nation really played a core role in developing these dashboards. Their team, basically, we tell them our vision and they were able to achieve it since they had that data connection established already. And so we provided the parameters as to what constitutes a positive test result, which lab values should be included, which disease incidents for surveillance purposes should be included, which really was a learning curve because Choctaw Nation has operated as a healthcare organization for many, many years. And so there's, of course, those differences between what health systems look at and what public health necessarily looks at and considers a case or not a case. So really getting everyone kind of brought up to speed on that was some of our initial roadblocks, but it smoothed over super easy. And so really looking at the schematic there, you can see a patient would visit a Choctaw Nation healthcare facility. That ELR, the lab report in our system would go into their health record. And from there, on the back end, our dashboards were able to pull that data and update it every 24 hours. So this would allow us to review and reflect upon the disease trends really on demand at that point. And so kind of for individuals thinking about this, some other internal sources you could look at, would, of course, would be the electronic lab reporting systems like Orchard or other systems available, ECRs, ELRs, and other health record management platforms. And so from there, we've since transitioned to Epic and our connections have been restored. There's a bunch of internal dashboards available instead of having to rely solely on external ones. But when you look at that, you're really able to use disease surveillance in a tribal healthcare system and really tribal government in general for many, many purposes that I think a lot of people don't realize. So it allows the public health department to gauge disease risk across the reservation, but also as a health system in general. And so we're able to also kind of have that dual approach as the healthcare organization and also as the public health authority for Choctaw Nation. It allows us to notify our CNHSA leadership, our clinicians, and our healthcare associates on emerging and heightening risk of disease trends using these real-time surveillance findings. And then this also allows public health to monitor and respond to our emerging or worsening disease trends that might significantly affect healthcare operations, patient well-being, or the public health interests of the Choctaw Nation. And so, thinking back to those COVID days, of course, the public health department had not began at that time, but you could imagine just the free for all that all of us were facing across the United States, but really how this could have been beneficial during that time period. And so over here on this side of the screen, you'll see a couple of the examples where we utilize that disease surveillance data. So during respiratory virus season, a weekly viral respiratory update is sent out system-wide to all CNHSA healthcare associates, keeping everyone informed of those disease risk and trends. And then we also work to send out quarterly disease reports to leadership and designated associates so that we know what trend we're seeing kind of long-term, longitudinally across the year. So really a non-traditional use of this public health surveillance that we've seen really great success with is partnering with the Choctaw Nation Child Care Centers. And so we operate multiple child care facilities across the reservation. And of course, as we know, they're some of our most vulnerable populations. And so we partnered with their leadership team to provide those same weekly reports that go to our health associates. We share those with their leadership and their health team as well, so that they're aware it allows them to take those proactive approaches within those facilities on a county level basis. And so I think that's been really important to this partnership here is it allows them to tailor which counties need greater protection, which counties are seeing a surge in flu, which counties are seeing RSV or pertussis coming through, and really how we can protect those facilities greater. And so we provide outbreak support and mitigation assistance to reduce the disease spread within those facilities and also to prevent operational disruption within the childcare realm. Something else that we've really seen as successful with these disease surveillance systems is bringing awareness to the public. And so I know a lot of people have mixed opinions on really sharing disease risk. And I know there's a bunch of information fatigue, especially post-COVID. But what we've seen is that our population has been very responsive to bringing attention to what disease risks are present within their communities. I think our members and then communities as a whole appreciate being informed, really, especially those with immunocompromised immune systems or their families or loved ones. It really allows them to take action and reduce the risk of long-term health consequence from that infection. It allows us to monitor emerging disease trends. So, of course, we know earlier this year over into Texas, we were seeing some measles cases, and we're concerned with them eventually making their way to Choctaw Nation. And so that allowed us to update our internal system so that in the event that we have a measles positive case come through, we're notified immediately. It allows us to issue public health advisories to address emerging public health risk and really let the public know that the Choctaw Nation is working to protect them. And we're monitoring the situation. We have these systems in place now to where we can proactively take a look and see, do we need to be pushing out any public health resources to these communities? If we do have that, do have a case appear, we're prepared and able to respond. I think another core component that we found really beneficial with having these disease surveillance systems is grant funding. Being able to have the data readily available to pursue those funding opportunities where you might not traditionally have that information, especially if you're having to rely on the state or federal government to provide that information. And of course, we know that that's not going to be the most up-to-date information available. And so using that with our disease surveillance system, one of the first findings that we come about was, we were seeing the rise in syphilis cases that most of Indian country was as well. And so doing that, having that data available allowed us to really go in and decide, okay, we need to prioritize this as a public health risk and launch disease intervention services within Choctaw Nation. And so doing so allowed the tribe to exercise our sovereignty. We've absorbed these DIS services from the state of Oklahoma, and we've been able to work with the state to where we can reduce the workflow on state associates while also doing exercising public health authority for the Choctaw Nation and doing these services internally. And so really we're bringing it full circle to where an individual could go get tested, screened, treated, and contact trace, all outreach and services performed by the Choctaw Nation. And so doing so, we currently utilize the state's disease surveillance system so that we both are able to view the readily available data, but it's really worked out well, and I think it's improved our workflow, and it's really increased our ability to reach patients who the state might not have been able to reach before. Well, there we go. Like I mentioned, we use the disease surveillance for new public health program development. So really one of the cornerstone programs that we started during our first year was tick-borne disease surveillance. And so traditionally, Rocky Mountain spotted fever was one of the most predominant vector-borne diseases within Choctaw Nation. Using these internal dashboards, we were able to identify that, pivot, and start tick-borne disease surveillance to identify which counties have which pathogens are prevalent within each county, but also which counties are at additional risk. And so it really allows us to tailor that approach again, identify which communities have greater risk, and really formulate that plan to address that public health issue. here's an example of kind of some downstream results of the surveillance. And so we identified the problem using these internal dashboards. We launched a tick-borne disease surveillance program, and now we've launched the Choctaw Nation Tick Guide. And so that identifies which counties within Choctaw Nation have various pathogens identified. Some have Ehrlichia, some have different forms of rickettsia. And so, really, I think it brings it again full circle and shows really using that data and turning public health data into action and meaningful impact within our communities. And really looking at the future plans for Choctaw Nation, we are currently implementing an ECR connection as well. We actually just completed the training with RCKMS last week, and we're receiving funding support from the NIHB, which has been very helpful, very beneficial. We've been very grateful for their support. And so our initial reportable condition will be limited due to implementation constraints, but we do plan to expand it. And so our initial list will include syphilis, alpha-gal, and Rocky Mountain spotted fever. And so we initially have scaled back this list to these three conditions, but we do plan to expand that once we're able to implement a full-scale disease surveillance system, whether that be a CDC project or whether it be a one of the out-of-the-box uh, secondary market systems like Maven, Epitrax, what have you. And so I think really a key takeaway from this is implementing ECR and ELR. Tribes exercise their public health authority, their tribal sovereignty, and they can gain independent data separate from relying on the state and federal healthcare sectors. And I think really right now, especially, that's very important because we're seeing these delays. We just got off of a very long and extended federal government shutdown. And so if we were having to rely on the government to provide that information to us, of course, they can provide significant future delays. And so, really, it just keeps us in best practices. It allows us to control the data and really exercise that data sovereignty component of it all as well. So, in summary, tribal nations have many internal operations to develop disease surveillance outside of traditional public health surveillance systems operated by the state. That can include EHR data, electronic lab reporting, and electronic case reporting requirements. Establishing real-time disease surveillance can be extremely beneficial when working to identify not only public health risk, but also risk pertaining to a tribal healthcare system, especially when we start seeing multiple facilities. It allows us to have greater data for grant writing and new public health program development, as you've seen. And then having a team or contractor to establish and maintain that internal data stream plays an important role in establishing an internal disease surveillance program, as well as the internal public health capacity to set those parameters or determine new disease incident criteria. Disease surveillance is extremely beneficial in the tribal healthcare sector. It can improve diagnostics and provider awareness of heightened disease risk, and it can also play an important role in the non-healthcare sectors of tribal government, just as you've seen in the tribal healthcare or childcare facilities, food service operations, and then, of course, leadership awareness. I believe that is all I have.
All right, Mason, that's great. And I want to congratulate you. Um, I believe you guys are live on Epic right now. Is that a true statement?
Yes, sir. We went live several months ago.
That's a amazing feat in itself, and so congratulations and that. Um, be, Before I open it up to the audience, I just wanted to ask a question of you and Dr. Coles. Since both of you are using technology, the ECR, which is just here in the past few years, was one of the technology, one of the things that was driven primarily by CDC and everything. Where do you see technology in the public health space 5, 10 years from now? Do you see a trend coming again that maybe I mean, you guys are using dashboards in your facilities in your area, but is there something else that's coming? If anyone knows anything about me, I'm a tech nerd, so I am very interested in it. I got a bunch of questions, but I don't want to monopolize the whole time. But I am so curious of what you guys think is in the future of public health as far as technology wise goes.
You know, I think we will see some advancements, especially with AI. Of course, it's being integrated into everything possible right now. But I think we'll see some reduction in, improved the systems. I think will improve in catching duplication. I think we'll see reduction errors in entering things and really improvements in overall workflow. I think one of the biggest issues we're seeing right now, of course, is just getting everyone caught up and catching up ourselves to ECR and the
Yeah,
data. These systems have been available to states for many years, but really right now on the tribal side of things, we're really playing catch up to try and
right,
exercise that public health authority.
right.
Yeah,
Dr. Cole?
yeah. I'll just add briefly. I'm not actually up on too much on technology. I feel like we're just catching up so much. As you're saying, like ECRs came in a few years ago, and we're just getting into that now. I'm hoping there's more standardization. It's like which EHR you had depends so much on what when you can
Yeah,
access, how you can do things. So, I'm really hoping there's actually more policies, not just also around AI. And then on another point, but just more standardization. So things are easier to use and more universally applicable because like it's so tough right now. Like we get the variances by EHR through AIMS is huge, is humongous. So definitely need more standardization.
all right. I will open it up to the audience. Does anyone have questions for our guest speakers? Anyone? Don't be shy. Well, like I said, I have other questions. So I'll ask both of you. This is the other one. How important was it for you guys to be the public health authority for your tribe? Um, can you, and I think Mason, you just kind of talked about that briefly on your last um, talking point, the shutdown in the federal government, and this, and with states losing funding, you know, how important is it for you, for your tribes to be your own public health authority? And basically, you're taking care of your own. I mean, can you expound on that and a little bit, both of you? Go ahead, Dr. Coles.
Oh, sorry. Not being a tribal member, I guess I'll hesitate a little bit, but I'll just say in terms of getting any of this set, like I think like Mr. Emmerich says too, it's absolutely essential. Like you can't move forward unless you have our public health authority. So for us, like we were actually quite delayed, like 8 or 9 months in getting connection to AIMS because there was discussions amongst between the tribe and the clinic about the public health authority. So without that, we wouldn't have been able to move forward. So it's just like I said in like my like the lessons we learned is the legal side is instrumental. You can't move forward without it.
Mason?
I totally agree with that. I think for Choctaw Nation, we find it critical to exercise our public health authority. As a sovereign nation, I think it's our responsibility to take care of our own and to be prepared to respond to those public health matters. And of course, as we've seen during COVID, a lot of us were not prepared, both tribes and states. It was somewhat unexpected, but I think exercising that authority. And really setting the boundaries, letting people know that Choctaw Nation will control the data going in and out. And we've gone as far as requiring, a lot of these federal systems are antiquated. They've not been designed for tribes to send data directly, and they rely on us sharing that with a state and them being our proxy. And so, data as minute as mosquito surveillance data, we held firm in that Choctaw Nation will not be using a proxy to submit this data. We are a sovereign nation with sovereign public health authority. And so doing so, we were the first tribe in the United States to directly report vector-borne disease surveillance data to CDC. And so I think that's a win not only for Choctaw Nation, but for every tribe.
Yeah, I couldn't agree more. I do see some questions in the chat. So either one could answer this. Could you describe whether communicable disease data is reported or shared with NNDSS? Is there interest to keep tribal data within the tribe for tribal use only? Thank you. Great information. So that's from my sister, Kim.
Um, so I know we are not reporting to NNDSS. I think it's a national notifiable disease surveillance system at all. When I checked their website, it says just states report to that. So we've never been contacted at all by CDC or anyone. And I'll say too, and this is just for California, and just from our experience, we are, like I mentioned in the slide too, we are still reporting our communicable disease data to the states. So I don't see this as a way the tribe can have sole access to the data, because there's kind of like two paths. It's going to the state and it's going to us. Um, so I haven't spoken to my board yet on the details of like owning the data. I know like Mr. Emmert says, it's really been fantastic for us to be able to do our own analysis and do our own tracking, and that was super important during COVID too. But the state still has the data that we have. We're just kind of like duplicating it for our own system.
Gotcha.
And that's the same for us. So the nation has traditionally reported to the state of Oklahoma voluntarily, just like all other non-tribal healthcare facilities. They've maintained the reporting up to CDC. And as we implement ECR, at least upon initial implementation, we don't plan to absorb those services yet. We do plan to work and get a system eventually that will be interoperable with the state's disease surveillance system, so that we both have full access to the data, but our systems can communicate and reduce the risk of duplicative work between state agencies and Choctaw Nation agencies.
Yeah. There is another question from Brian Ramos, and this is always a big topic, interoperability. Do you have integration needs between AIMS or other systems, or do you still find that you have more interoperability needs within your own systems or with other nations? Either one.
I would say for us, it would be great if we had access to CalReady, like the state surveillance system. Um, that would really kind of change things for us. But again, I think it's like a legal issue that I honestly don't know the full details of. But since we don't have access, we have our own systems, and we coded it ourselves, like basically the interoperability, the integration and engine. So it's doable. Like I know other bigger states, especially use like Rhapsody or Mirth. We were able to code it ourselves to integrate the incoming AIMS data into our surveillance system, and it's not perfect, but it's working so far. And we saw people review things manually, like we have like a manual check for some files. So it's not perfect, but our caseload is so small that we're able to do that, to do some of that manually and then some of that through our code.
Yeah.
I would say very similar for us as well. I briefly discussed how we launched disease intervention services for our STI cases. And so we're utilizing the state system there. Since we do not have a full scale disease surveillance system, we're using the states, so that we're both have access to that data. But our interim goal, once we get a disease surveillance system in house, is to get an interoperable connection between the states and ours. And so the state of Oklahoma is currently working through updating their systems. I think they've got some vendors identified and procuring. And so we're hoping to get a system where the same system that can connect, communicate, so that case data can go between both entities.
All right. Uh, Another question. Let's see. Ronette Yarden, what is the situation with disease surveillance on chronic diseases? That's kind of broad, but
Yeah, I'll say we're, at least for us, like, we use RCKMS. RCKMS is a system where that kind of they define cases. There's, I'm sure someone on the call knows, but I think there's a few hundred conditions and diseases within RCKMS. Very few are chronic. They're mostly communicable and kind of infectious diseases. Um, and I don't think they have any. It's such a huge. It would be such a huge lift to add chronic diseases in there that I don't think there's any immediate motion for it. But if you're able to have your own system or using your own EHR, you can track things that way. But through RCKMS, I don't believe they have any chronic. They have many chronic diseases available for tracking right now.
We have interest in it. And so, like Dr. Coles mentioned, the in-house EHRs, of course, you can track a trove of data there, especially among your patient population base. But really, an avenue we're looking at exploring and really taking advantage of with ECR is some of the chronic disease conditions. But like mentioned, the list is so broad, it would take up so much server space. We just currently cannot feasibly get that going at this point with just the initial implementation. But I think we're looking at it as an avenue and vehicle to track some of those chronic conditions and see if there are any noticeable trends, especially with conditions that you really don't hear much about, or especially on the disease surveillance side of things. Even as I think one of the conditions is overdoses. Some of that information coming into those facilities, or I think one might even be suicide or car accident. Identifying which counties are having those risks, which population base do we need to target, not only for intervention, but also to provide additional services to.
Yeah, because then you'd want to work with some of your behavioral health department as well on some of that.
Exactly.
And states are limited. As you know, Mason, here in Oklahoma, we're at the bottom level of healthcare. So let's see. Let's see, there's another question, looks like from Marion Cardenas. Can you speak to reporting to local health departments in states that use uh, local governed health departments versus directly to states? I don't know.
Yeah, I can say for California, we did research into this to understand their system. So I know there's like centralized versus decentralized state health authority, and I believe in California it's decentralized at the county level, but they use one surveillance system. So we report, so our clinical staff, it's part of their state licensure requirements. As a licensed clinician, they have to report reportable conditions to the state, and then the state kind of like they have a system that gives every county access to the cases within their county. So we only report once, and then the state kind of like divvies out the data basically. But I know that varies tremendously by state.
Oklahoma is a centralized state, and so it operates really similarly to California, where it all is going into that central system. The difference is Oklahoma's remains in that central system, whereas California's kind of gets divvied out to that local level.
The next question looks like from Jessica Musher. Have you have you added indigenous social determinants of health to your system? If yes, have you acted on that information? If no, what steps have you taken to meet the non-medical needs like homelessness?
Honestly, that's a gap for us. I think that's something we're still trying to fill in. I would say like I showed on the last slide, the flyer we like kind of ended on in like in the later COVID in 2022, 2023 had other factors of health. For the tribe for Tule River, it's important air environmental health, like environmental health issues. So we added that in. So I'm hoping if we able to develop a dashboard in the next year or so to add in other data sources too around air quality, around weather, because they have flooding and they have heat issues too. So keeping that like broader view, but I don't know how AIMS could include that, like how ECRs could include that stuff directly. But that's a really good point. That's something we should look into more.
We haven't really approached this on the AIMS and ECR side, but it is something that's been integrated into our Epic system launch. And so, using some of the social determinants of health features in it, we're able to start measuring some of that data better, especially homelessness. What social determinants of health are they facing? And we actually just wrapped up our recent tribal health assessment. And so, working on our health improvement plan. We've actually identified several of those data sources within Epic that we'll be utilizing in the future, since it'll be a direct measure from that population base as they come into our facilities.
Okay, we got another question from David Pashkin. The health technology market is moving towards centers or foundations that test the efficacy of AI, patient level, and service operational tools to reduce the cost, risk, and increase the testing. Do you believe that your respective tribes would benefit from and want such a model if a federal agency funded it?
From the Julia side, I would say it would be extremely hard for us kind of at an organizational capacity level to handle any more like things that help. I think we just need to kind of deliver care, deliver a resource, like deliver services directly. If there's a giant leap in service delivery, that would be something we're interested in. Like that's something that would benefit the clinic, but kind of more evaluations, more some anything that would make our clinical staff do more would be a non-starter. That would just be too much. But that's just my view from where I sit.
I agree. I think one of the biggest challenges in any healthcare realm is getting staff buy-in, especially when it's the direct clinical care staff who's run thin on time already. And so I'm not really too sure on how to answer that. We've just undergone a massive data system transformation in Choctaw Nation, switching from RPMS to Epic. And so we're still really getting the bearings and getting everything in place with that. So I'm not really too sure on how to approach that.
And that had to be a massive chore, especially going from RPMS to Epic. Yeah, I'm sure you had a lot of individuals that loved RPMS that didn't want
Right.
change. And
I was
change is
I
always
was
hard.
big. Oh, go ahead. I'm sorry.
No, I'm just saying change is always hard sometimes.
It
Yeah.
is, and it's a big transition from a system like RPMS to Epic. But it's been very welcome, at least, on my end in terms of looking for epidemiological data. Um, Choctaw Nation has had a wonderful team overseeing that transition, and I know they've been working and still working very hard on getting that data migrated over.
Yeah. Do we have any other questions? Anyone have any other questions for?
Robert Coffey, I see a question that came in earlier from Cheyenne Jim.
Okay.
It reads, how long did it take you to get to this point? So for Choctaw Nation and Tule River.
For us, like I mentioned, we started, I think, similar to Dr. Cole's back in 2023. And so it didn't take very long at all. Honestly, we had our internal dashboards up and running in about a year max, which of course we were blessed to come in and our health analytics team already had the data stream established before the department was formed. And we're a very small department. I always like to mention that when discussing you don't need a whole slew of staff like you traditionally think of with a state health department agency. With Choctaw Nation, I, I'm the epidemiologist, so we have a public health director, and we started with an accreditation officer, and so we had three individuals in the whole public health department. And now we significantly grown once we developed that baseline data to see where our needs were.
Yeah, and so yeah, I would say like the travel resolution that kind of got us kickstarted was in November of 23, and then we connected in the summer of 2024, officially to AIMS, and then it took us about a year. But I would say too, like I see Turtle Mountain is on too. Um, like it was tough because we were one of the first, but I think it's going to get easier. There's going to be more resources. I know the CDC is already offering more resources, so even that it's probably going to be taking especially NIHB too. They've also offered great resources, so hopefully it's getting easier.
All right. Is there any other questions? Anyone have any other questions? Okay, here comes another one. Kim Blackhorse. Could you describe how externally data owners, like states or so forth, can be accountable to implement or acknowledge tribal sovereignty and tribal data sovereignty principles that would improve sharing and add to collective benefit. Thank you for sharing your great work. Glad you're on, sister.
Yeah.
Anyway, go ahead.
Yeah, just from a process perspective, I'm a little hesitant to go like into the details from being just staff, but uh, how I see it potentially like kind of more tribal data issues is that if the data went to tribes first and then tribes could decide whether to send the data onto the states or not. But that's not how it works right now. That's not how it works in California right now. Um, yeah, that's all I have to say.
I would agree with that. I think it's very hard to hold external organizations kind of accountable when predominantly that data is fed to them directly. Of course, you're not the intermediate. You can't put that stuff there when you're not involved in the system to begin with. And so, I think really looking in a forward movement direction, ironclad data share agreements. That is something we have been implementing for every new project where we partner with external organizations. Like I said, currently we have a great working relationship with the State Department of Health in Oklahoma. But when we get to looking like our mosquito project, we required a data sharing agreement between us and the state of Oklahoma. There was reciprocal between both of us. We will transmit our mosquito surveillance data findings to you, but we expect the same in return. And I think having those conversations and setting the expectations up front from a programmatic side of things with public health services as you establish new things and programs is critical because it sets the expectation. And you can also outline what use and data can be externally shared, how they can utilize it, what permissions would be needed before it could be used. We require, for some of ours that they obtain approval from us. Some other projects have to go through the Choctaw Nation IRB board. So it just kind of, varies, but I would say having everything outlined, kind of from the get-go.
And I think the both of you have shown that Tule River and Choctaw Nation, I know there's other public health departments across the Indian country that now you can more than ever to exercise your tribal sovereignty and work with states. I know some states may not be friendly, um, but you know that's your right to be the sovereign nation you are, and so continue to let those states know that you are in control. So I love that about what you guys, the work you guys are doing, and especially taking ownership of that part and letting the states know. And before too long, I think they'll be coming to you for more information on that. Let's see. We got another question here. Why is there so little public health in Indian country? One public health nurse does not make a public health program. There are only 8 certified public health programs nationwide. My tribe, Paskayaki, is certified, and it has made all the difference in our quality of life. I think it's a very general question, but
Uh, I guess I could start. I think a lot of it is at least in our instance, so Choctaw Nation's provided public health services for years and years and years. It just has never fallen under a traditional public health department. And so I think we realized that, especially coming in, starting the department about 3 years ago, is that there's so many public health services being provided. They just have not been quote unquote categorized as public health. And so really working to identify those programs, but then build upon it. I don't think there's a lot of awareness of the role of tribal public health departments or even tribal public health authority for that matter. A lot of individuals aren't aware that the tribe has inherent public health authority. But I think we're seeing a greater awareness of that as we start seeing more tribes work to improve that capacity.
Yeah, I agree with Mr. Emmer. I think that's it. I can't explain it either, but it's definitely something that in my opinion, would need to go and is I'm optimistic about the future with where things are right now, but it's a really great question.
and I think if anything, COVID was probably the biggest one that really pushed us to the forefront. And in our state, um, we found out that our county public health departments did not have the resources at all to do testing, to do um, surveillance, and all of that. And it was the tribes that really were the backbone that really helped in the communities provide testing, provide some kind of surveillance, letting people know. And then on the back end also became the vaccinations followed right after that. So, um, you know, if COVID taught us a lesson, it's one lesson that maybe, you know, one of the things is tribes taking care of their own. And you guys have definitely done that. Um, I know we're getting close to short of time. So uh, I just wanted to appreciate our guest speakers, and I'll just let you guys give us one last final thought before we step aside here.
Yeah, I'll just say for anyone who works at the tribe who's interested in it, is like it's doable. Like, as Mr. Emmert says too, like it's you start with like a really small team. We have 3 people in our department right now, but we're hoping to grow. So yeah, I think it's always achievable. Like I tried to point out, there's multiple ways about it. You can go with big, you can go small, you can go really really small, but really to start it, because it's something that definitely can be done.
I'd echo that. I think it certainly can be done. And I think looking at what other tribes have done already in the past is super beneficial. We've reached out and spoken to other implementers along the way. I know I've sent, I don't know how many emails asking, how did you fix this problem as soon as you run into that roadblock? And, it's a challenge, but it's worthwhile. And I think it really, once you get started, you see the benefits, especially within your tribe. And I think it gains traction very quick. So I think it's worthwhile, and especially worthwhile to exercise the sovereignty aspect of it all.
Yeah. Sophie, you have anything you want to say?
I just wanted to thank everybody for attending and for all the questions and lively discussion. I also just want to remind folks the session evaluation link has been posted to the chat, and we will send that in follow-up emails as well. And yeah, thank you to Eric Coles and Mason Emmert for really great presentations, and for just showing us the work you're doing on the ground, the very valuable work. And thank you, Robert Coffey, for this November coffee chat in which we were able to co-host.
Yeah.
Yeah,
Yeah,
thank you.
no. Again, thank you, Dr. Coles. Thank you, Mason. Really appreciate you coming and just chatting with us and telling us all the great work you're doing and your community. Um, y- Hopefully, you may have inspired someone else to just like, you know what? If they can do it, we could do it too. We may be small, but just like you guys, you started small as well. So we appreciate that. I hope everyone on here, everyone has a great Thanksgiving and a great holiday season. And if you're in Oklahoma, I hope to see you soon. All right. Thanks, everyone. We appreciate
Thank
the
you.
time. Yeah.
Get cookie, everyone.
Oh, see you soon.